Welcome, everyone. My name is Terry Lakowski, and I'm the Program Director of Support Group Services for Us Too. Tonight, I'm going to be your host and your moderator. So that's going to be fun. So welcome, everybody. This is our fourth session of the S2 2021 webinar series called What is Right for Me in My Prostate Cancer Treatment. This is a discussion on the topic of imaging. Continuing advances in imaging technology and usage can mean more accurate testing and diagnosis related to prostate cancer and can help guide patients toward the best treatment options for them. So we have a really full show for you guys tonight. Tonight's webinar is sponsored by Pfizer Astellas, Blue Earth Diagnostics, and Progenics. We are always super excited to tell everybody that we've had almost 500 folks who registered for the webinar tonight, and we have people joining us from all over the country, the US, Canada, the Bahamas, Australia, the UK, India, Finland, Jamaica, Mexico, to name a few. So I always love telling that. I think it's really fun to show how we're really expanding our reach here throughout the country. One of the challenges men face in selecting a treatment plan for prostate cancer is that there's no single standard that applies to every situation. With this webinar series, What is Right for Me in My Prostate Cancer Treatment, Us Too will try to help patients and their caregivers understand their options and provide information to help each person make the best choice for his own unique circumstances. So I want to mention a few housekeeping items for tonight. Due to the length of and the depth of our program tonight, there is unfortunately no room for questions. We have gotten hundreds of questions that have come in ahead of time. When Dr. Helfand does his presentation, we have really put a lot of the questions into the discussion that we'll be having with Dr. Helfand. And if we have a little bit of time at the end, we have some questions ready to go that were submitted for Dr. Klotz, but we're going to be really crunched for time today. So I just wanted to mention that to everybody ahead of time. So we are thrilled and really honored to have our two presenters here tonight with us. First of all, we're going to have Dr. Brian Helfand. Dr. Helfand is the Chief of the Division of Urology at Ronald L. Chez Family and Richard Melman Family Endowed Chair of Prostate Cancer at NorthShore University HealthSystem in Evanston, Illinois. He's a clinical associate professor at University of Chicago, Pritzker School of Medicine in Chicago. He holds MD and PhD degrees and is head of clinical and research programs focused on prostate cancer. Dr. Helfand has authored more than 200 peer-reviewed manuscripts. Currently, his interests are devoted towards using novel imaging techniques and biomarkers, including genetics, to help guide clinical decision-making for men with newly diagnosed and advanced prostate cancer. We're also thrilled to have with us tonight Dr. Laurence Klotz. Dr. Klotz is the former chief of urology at Sunnybrook Health Sciences Center and former president of the Urological Research Society and the Canadian Urological Association. He currently serves as professor of surgery at the University of Toronto and holds the Sunnybrook Chair of Prostate Cancer Research. Dr. Klotz was the founding editor-in-chief of both the Canadian Journal of Urology and the Canadian Urology Association Journal, and is now editor emeritus of the CUAJ. He is the founder and chairman of the Canadian Urology Research Consortium and is also the chair of the Global GU Oncology Group, and I'm honored to say he is also a board member of Us Too. I also just want to quickly say before we get started that the information and opinions expressed in this presentation are not recommendations by Us Too for any medical treatment, but or course of action. So be sure to consult your doctor about your specific situation before embarking on any health program. So we're going to start today by introducing my good friend, Dr. Brian Helfand. Thanks for joining us tonight, Brian.
Thank you for having me.
So, like I mentioned a little bit, our discussion with Brian tonight is a compilation of questions that were already submitted. So it's going to be a little bit of different style of what we've done before. But I'm going to start out kind of with a general question for Brian. Can you give us some background on next generation imaging? So, like, what's the deal? Like, what's going on with that?
I love it. So again, and thank you, Terry, and us too for inviting me to speak. And certainly this format is a little different than typically what we do. So bear with us as we kind of go through it. But again, all of these are really based on questions that have already been submitted and hundreds of them. So one of the things for those of you who know me on this Zoom is that I really believe in personalized decision making. And really that comes into all aspects of prostate cancer care. Certainly that comes from the time of diagnosis to the time of treatment. And then certainly if you have recurrent or metastatic disease that's not responding to therapies. And I think a little known fact is that after treatment with curative or non-curative intent, whether it's being surgery or radiation or hormone therapy, 40 to 50% of those patients are going to recur over time. And, historically, we didn't have the best technologies, okay, to really image where they were. And we would kind of give people a one size fits all type of treatment for those recurrences. And if it didn't work, so be it. But that was all the options we had. And I should clarify what I mean by recurrence in this process is that when you have recurrence, that means that you did a treatment and that disease has come back. And it's not always in the prostate. Actually, the vast majority of time, it's throughout the body. It's in lymph nodes, it's in bones, etc. And so again, you can follow someone over time. And after a treatment, if their PSA, which is the most generalized used blood measurement over that time, starts to rise, we want to say, hey, that disease has come back, but can we locate where that disease is and come up with an individualized treatment plan that's right for that patient? And again, historically, when we were trying to image or locate where those recurrences were happening, we really had access to bone scans and CAT scans, and more recently MRIs. And MRI improved some of that. But when we look at the data regarding the sensitivity, the ability of those technologies to pick up where those recurrences were, they were pretty low, meaning that you'd have to wait until a PSA value was really greater than 10 to really detect something on a CT or bone scan. And MRIs weren't great and aren't great at imaging other, kind of bony or non-bony structures in the pelvis. So there were limitations to all of that. And the problem with it is that if you had to wait that long until your PSA was so high, perhaps we were missing a better treatment window. And we certainly know from many studies that the earlier you can treat a recurrence, the better patients do. So there was a need for what we now refer to as next generation imaging. And that really refers to what has now commonly been called PET-CT scans or CT scans that are also combined with a radio tracer as part of a PET imaging study. And I think most people on this call are familiar with that. But in that next generation imaging, we really have many different flavors which have come into being. So this all started initially with something that we call a choline PET CT scan. And this was largely just based at certain single institutions. But in fairness, that choline scan really was able to pick up a lot of recurrences at lower levels. So PSA values around 2 or so, but they kind of improved the mark there. And that kind of became a standard which all next generation imaging were measured against. But the problem with choline scans and the reason why they were at so few institutions is that molecule, that radio tracer that's uptaken by those cancer recurrences is relatively unstable, meaning it only can exist for a short amount of time after it's made. And so you can't transport that across the country. And so with that came the advent of newer next generation imaging, if you will. And that came into flucyclovine studies or PET CT scans, or which have been known as Oxymon studies. And these really then became widespread, and currently are the most commonly used PET CT imaging that we know of in the space of prostate cancer recurrence. And what these do are they're uptaken by the radio tracer that's tagged to Oxymon are actually uptaken by amino acid transporters, specifically by these prostate cancer recurrences. And that moved the bar even further because we could detect prostate cancer recurrences at even lower PSA levels. But if that wasn't enough, and to even confound and move that needle further, within the past several months, we now have several FDA-approved PSMA tagged PET CT scans. And there's a number of those, from a gallium-based to a fluorinated-based. The most recent one, the fluorinated-based, is known as DCF pill or pile, people will call that. And these are all kind of variations, but the radio tag is actually tagged to a PSMA molecule, a molecule that is expressed in prostate cancer, advanced prostate cancer, and has variable expression in hormone therapies. Nonetheless, is that these are also have a lot of potential to detect recurrences. And I think it's with that as kind of a background that we can kind of move into a lot of these questions of saying, today where we stand is, how do scans like the Oxymon scan or some of the potential of the newer PSMA scans, how can they help us really define where prostate cancer recurrences are and kind of and help us come up with more personalized treatment plans for patients?
So yeah, so we did have a lot of questions on Oxymon. So that was great. Thank you. So my next question here is, with recurrent prostate cancer following radical prostatectomy, at what PSA level should an Oxymon PET CT scan be performed such that it is likely the tumor would be found?
Okay, excellent. So again, if you have a recurrence, when should we start getting a scan? And I think that's a subject of debate, and certainly there is no prescribed levels where we should get these scans. But of course, we know the earlier we can intervene, the better potential we can get this at when the recurrence is at a small size and potentially more treatable. And so again, just to make sure everyone's on the same page, after a radical prostatectomy where we remove the entire prostate, a man's PSA should go to 0 or undetectable. And that level of undetectable is going to be variable based on the assay you use. Nonetheless, it is agreed upon that once a patient has a PSA level of 0.2, that we call that a recurrence. So if we start getting that PET CT or an Oxymon scan, or even now a PSMA scan at a low level, we want to, it has that potential to localize where that cancer is. But we have to understand that even though these are next generation imaging technologies and they have moved the bar tremendously, they're still not perfect. And when we look at very low levels, and in some of the initial trials with the Oxymon and some of the PSMA levels, they have looked at it at levels, up, down to, and below 0.2. We're going to have about a 30% or more positive rate. And it depends on how you look at that. Certainly when I counsel patients and I say, hey, your PSA is still low, but it's starting to rise and we're coming close to a recurrence, there's about a 30 to 40% chance that we are going to find cancer at this low level. Is this something you're interested in? Most of my patients say, yes, I'm interested in it. Let's go ahead with the image. Having said that, there is variable coverage based on some insurance companies until certain PSA levels. But in the ideal world, if we had our choice, I do believe that getting imaging at these low levels is very helpful to localize recurrent cancer.
Awesome. So how do you see imaging guidelines for patients with prostate cancer evolving over the next few years?
So currently, the most widely used guidelines that we have are in the National Comprehensive Cancer Network, or NCCN guidelines. And right now that they currently recommend or to consider using a choline scan or that flucyclovine Oxymon scan. Obviously, at the latest update, PSMA was not widely available. Actually, it still is not. But I expect that these will ultimately include PSMA scans as well. And there may be a role, and I didn't talk about this, even later down the line for other scans, FDG scans as well. So I do think that there's possibilities to incorporate into other guidelines. And again, the importance of having this in the guidelines is, and the real world part of this is, in order for insurance coverage, we usually need this to be in guidelines first.
Thanks. Thank you so much. Okay, here's another good one. What is the lowest PSA level at which imaging PET-CT agents are mostly likely to be productive in managing courses of treatment?
So again, that is kind of back to what I said a little bit, in that there's not a best level. Certainly, we recognize that the higher your PSA at the time of recurrence, the more likely you're going to have a positive scan. In fact, once you get to a PSA value of 6 or 8, there's an 80-90% chance that we're going to have a positive scan and something that we can work off of. But again, in my opinion, for a lot of men, that's kind of too late. And the earlier we can intervene, the kind of better. And again, I bring that up at these higher levels, but all of these quote unquote higher levels that we can detect by next generation imaging are still far below what we previously had with conventional imaging, with a CAT scan and a bone scan, et cetera. So we have to take that into account. The other thing to mention is that I'll often get a scan on a patient and it's negative, and it's still at a very low level. As I counsel the patients, I always say, well, that's not a bad thing. We actually, in the ideal world, don't really want to detect always where that cancer is, and the likelihood following surgery that it's still confined to the pelvis for many patients is actually a positive sign, and certainly prognostically. So we do take that into account too.
So this one is kind of two questions here in one. It says, when do you expect PET scan using PSMA will be approved by the FDA? And when comparing PET scan using PSMA to MRI, how much improvement is there in accuracy of detecting prostate cancer?
Those are great questions, and certainly from a approval from the FDA standpoint, 2 PSMA agents have been approved. One is a gallium-based type study, so this is tagged to a radio tracer gallium, and the other one is a fluorinated PSMA scan. And so those are approved. Unfortunately, their widespread implementation is not there right now. But certainly I expect in the upcoming months and year, you will see a lot more of this. And I do also expect that you may see other FDA approvals of other PSMA agents coming to the table. So, and I bring this up because I'm excited. I like this, and there have been some randomized controlled trials comparing PSMA to Oxymon. And I also emphasize that if a patient gets an Oxymon scan, it's wonderful and still very, very sensitive. We still don't fully understand the differences between the Oxymon that amino acid transporter type PET CT scan and the PSMA. And I think a lot of that will be unraveled within the upcoming months and years. Ultimately, we may combine the scans because one may be more sensitive at lower PSA levels, one may be more sensitive for lymph nodes, et cetera. But a lot of that are still kind of ongoing questions about when and where to use what type of PET CT scan. I think if you have a recurrence, the most important thing is if interested to locate it, which I think that it should be for most patients, that you can get access to, a PET CT next generation imaging scan.
So how accurate are PET scans?
I think like anything, they have a high degree of accuracy. And this is a long-winded answer, but sometimes it's actually difficult to know because sometimes the targets that light up are actually difficult to biopsy, but certainly we have seen positive treatment responses. But I think with any technology, there's always going to be some false positives, meaning that there could be some extra signals for various reasons that are picked up for things that aren't cancer recurrence. And additionally, a small percentage of patients may actually have a false negative scan, meaning that there is a disease recurrence, but we actually can't detect where that cancer is. And certainly, again, at low PSA levels, there's going to be a higher rate of false negatives because we can't see it because it's still, we're talking about cells that aren't really lighting up. And that's true for the flucyclovine studies, the Oxymon, and is also true for the PSMA. So I think that goes for all of these. But again, have moved the needle so far that I think when we see a signal, we in general believe it. And if there are any questions, we at least have the options to biopsy that site if it's large enough to prove to ourselves that it is a prostate cancer recurrence.
Got it. So, okay, this is kind of a long question, but this is a really good question. And I do hear this a lot. So there seems to be a difference from one center to another for their skill with prostate cancer imaging. So what tips do you have for finding a good center to work with? And what would you suggest to men who might not be seeing a urologist or an oncologist as an approach? And should they really be advocating for themselves?
Well, I always think to start off with the latter question is that we, while we love our caregivers and while we trust them and they do provide a lot of care, I do believe that patients always have to be their own advocates. I think understanding what the technologies are and what's actually out there really kind of helps push and motivate the caregivers as well. And so I think that you should always be your own advocate, whether in prostate cancer or your general health, to stay on top of your treatment plans. I think in terms of the experience of a certain center, I don't care what we're talking about, whether you're talking about surgery, radiation, treatment of prostate cancer, treatment of blood pressure, for that matter, is I think the more experienced you are in anything, the better your outcomes are going to be. And so the same is true for any type of imaging, whether you're talking about a multiparametric MRI, whether you're talking about a PET CT scan. The more experienced a radiologist is and a center has with that technology, the better the outcomes are. I think as an example of this is that there have been several studies that really were with the flucyclovine or Oxymon scan. And at that low level, initially, in the initial trials that were performed at low levels with Oxymon, so that at low levels below a PSA of 0.8, that about 30% of men had a positive scan. Certainly over time and with increased experience in subsequent studies, one was known as the Locate trial, that at that same low levels and even lower levels, between 40 to 45% of those scans were positive. Again, likely reflecting that increased comfort and skill in that determining radiologist. So I do think an important question to ask any treating physician is how experienced the radiologists who will be reading those studies and administering their studies are with the PET CT imaging studies. And if not, can we refer you to a site that is hopefully nearby that has better experience over time? And again, there's not a standard saying, hey, this is our experience, but certainly a lot of the companies that offer will also have lists of institutions that have quite a bit of experience with this. So I do think that that's something, an important question to ask.
Yeah, thank you. So next question I've got is, what imaging can best detect cancer after a radical laparoscopic prostatectomy? Are they currently being used in the US, and what are your opinions of those?
So, I don't think particularly whether you're talking about a robotic or laparoscopic prostatectomy, an open prostatectomy, or even some of the kind of newer, radical or partial resection therapies, that we know what the best is. Certainly among the PET CT, we're going to have the highest sensitivity. And again, I think we can comfortably say, based on prior experience, that compared to MRI, compared to CT, compared to bone scan, it is certainly any type of PET CT, the Oxymon, flucyclovine, the PSMA scan, even the choline scans are going to be far superior in detection. So I think particularly those are ones to focus in on. But again, not to just focus in because I'm a surgeon, and certainly that's a vast majority of the patients I see, but we're also talking about men who have failed radiation, men who are on hormone therapy and their PSA starts rising. We can use these technologies, the Oxymon scan, et cetera, to kind of help localize where that disease or recurrence is coming from.
Yeah, and I did pronounce it wrong. Prostatectomy. Lots of heavy language, guys.
We love it. We love it. I've heard it called many things.
Right. So next question, and we hear this question asked a lot. Talk about the different cost implications of the different scans, and especially regarding what insurance carriers will approve and not approve. So I know that could be really complicated, and it depends, but we do get that question asked a lot.
Right. So that's a very variable question based on the type of insurance you have, and depending on where you are in this world. There's going to be various coverage. Certainly Medicare covers the vast majority of these, but on the other hand is many of the private insurance will have different regulations on whether they cover it and what kind of prerequisites need to be fulfilled before you're allowed to order a PET CT scan. And so again, not necessarily based on good or hard data. Sometimes these insurance companies will often require a CT and a bone scan first. Again, doesn't make a lot of sense since we're trying to get to a more sensitive type imaging. Some of them will have you wait until a PSA level of 1 or a PSA level of 2 based on various historic studies. But again, I think a lot of that has to be addressed over time. And certainly if there is any type of question, a lot of times those queries or coverage come back to the physician to have kind of peer-to-peer reviews to get those images covered. So that's a very long-winded answer to say is that there has been increased coverage throughout the country. A vast majority of my patients in the Midwest now are really able to get a lot of these next generation imaging studies. But a lot of times we have to jump still through some hoops in order to get the patients appropriate.
Do you happen to know the status of the Oxymon PET scanning on that?
Again, it is somewhat regional based. Again, I can say uniformly that Medicare does cover it, but it is one of those where a lot of the private insurances are going to be somewhat variable. Again, we have seen over time, really in the past 5 years, increased coverage by most of those companies. The kind of out-of-pocket cost, again, is going to be variable based on the institution that you have. And it is one of those where if you do contact, as an example, the companies who offer the radio tracer agents, they can actually be helpful in either reducing costs, if there is any, and or directing you to a center that may have it at more affordable rates.
Okay, so next question I have is, how do the accuracy of both a PSMA PET and an Oxymon PET scan depend on PSA levels? For example, what is the accuracy of each as a function of PSA level?
Right. So again, there has been data, even some comparative data looking at the two, and for uniformly as the PSA levels increase, both the Acumen as well as PSMA PET CT scans will increase in the number of positive scans, meaning that we can find that recurrence. There has been some data that does suggest that at low PSA levels, really less than 0.5, et cetera, that PSMA may have increased sensitivity. I think a lot of that still remains to be somewhat defined, but there is that potential. On the other hand is when we talk about, different disease states, meaning that if you've been on hormone therapy, we do know that, Acumen works quite well. We still don't know whether PSMA, once you've been on hormone therapy, will work at the same efficacy. So we have to take some situations into account there. But I do think, again, they both have potential to work well at very low PSA levels. And potentially will show more definitively that PSMA may be better in that space. But I think we're going to have to understand what space each one of those type of scans will perform best in.
Awesome. So I'm going to skip ahead a little bit here, Brian, because we're starting to get a little bit low on time. But let's see. I'm going to let's go to this question, because some of these questions I think you've kind of answered. So let's go with this one. Please comment on the expected date for FDA approval of the new GA68 PSMA PET imaging technique.
So that has been approved. So that's the gallium-based scan. Currently, you can get on the West Coast. And so in several California centers and some of the other centers are starting to open up. The DCF pile will be more readily available. That's the other, FDA approved scan. So I think, kind of time will tell based on their kind of uptake. And by the way, I should just say is the other name for DCF pile is, is the Clarify test, just in case, just to make sure everyone's on the same page there.
Any idea how soon after approval will Medicare cover those costs?
That I don't know. Again, sometimes we have to wait a little bit more before it's put into guidelines. Again, I expect updated guidelines to include the PSMA scan, so I think we can do it. Currently, there are centers out there, again, mainly on the West Coast, that there is a relatively affordable out-of-pocket cost that you can get. And certainly, there are still continued trials throughout the country where sometimes you can get these scans for free.
Excellent. So we're going to jump ahead a little bit here again. Oh, here, this is a good question. What is the state of the art in using imaging to detect the spread of prostate cancer after treatment? And what is the probability of detecting the spread? And then what's the percentage of false positives? So a lot of questions in there.
Right. So I think that again reflects a lot of what the imaging techniques that we use, and certainly some of that's we covered is that percentage of positive scans is going to depend somewhat on your PSA level and maybe dependent on the type of treatment that you have. Again, we just don't understand truly the effects of men on hormone therapy or not hormone therapy for some of these newer therapies. Certainly, the percent of false positives is low, and it's, again, kind of difficult to really estimate. There's a low false positive rate for all of these, but certainly understanding its limitations and based on the type of study you use is important. But a lot of that can be discerned somewhat as we move forward. And certainly a lot of this is, the way if you can't biopsy or there's a question, we often will discuss treatment and we can kind of monitor treatment response. One of the things just to kind of add and just to make cover is a lot of patients want to know, what do I expect when I get a scan? Is there, a lot of side effects or problems when I get the scan? And so in general, for any type of scan, we say, kind of the day before, don't do heavy workouts. We don't want your muscles to kind of falsely take up a lot of that radioisotope uptake. So we tell you not to do heavy exercise. And that can actually help decrease some potential false positive signals there. We tell you to be well hydrated. And certainly, going into the scan, you basically, will lay down, they'll give you a radio tracer to scan you. It's not enclosed, meaning that you kind of do go through, kind of like a CT scan. So there's a ring, but it's not one of those that's claustrophobic like an MRI. Typically, most patients have no side effects. I think the most common kind of side effect that patients can experience are potentially a little site of redness at the site of injection of the radiotherapy. Again, that's really rare and not life-threatening. Two is that, it's not uncommon where patients will, during the injection of the radiotracer, say they can experience a metallic taste in their mouth, or dysgeusia is the fancy name for it. But it's a very well tolerated procedure. We always say the worst case scenario would be that it would be an anaphylactic response, meaning you couldn't breathe during the procedure. I don't think that's ever been reported, period. But with any type of scan we do, that's always kind of on the label. Again, I think that's, kind of the simple way around it, that most patients don't need, kind of anti-anxiety medicines for this procedure because they're in a small space.
Okay, so gosh, a lot of good questions, but we're going to have to wrap it up here just because of time, because we've got Dr. Klotz on board here. But I'm going to ask you one more question here, Brian. Let's see. Here we go. Can imaging replace biopsies in the active surveillance program, and under what conditions?
So that's the hope for at least all my patients, and certainly probably a lot of people on this call. And so, imaging studies do hold that potential. Certainly in that way, forget next generation, but multi-parametric MRIs have moved the bar slightly, but they still, unfortunately, don't replace the actual biopsy. No one since has really looked in the active surveillance space if next generation imaging has a role. But remember, active surveillance, unfortunately, right now is not considered a failure, meaning that if you get a higher grade disease, so we're following you a low risk prostate cancer and it turns into a more aggressive type cancer over time, that's unfortunately not considered a failure in regards to the ability to get a next generation PET-CT imaging. So we don't really know if there is yet a role, and perhaps there is an investigational study out there. But right now is the best movement we've had there, which has made a big difference, is multiparametric MRI.
Well, thank you so much, Dr. Helfand. Do you have any last minute, just kind of a wrap up for everybody today?
So I think for everyone here it's a very, very exciting time. And certainly I didn't even have time to even talk about a lot of these radio tracers and their possible role as a therapeutic option with lutetium tagged and stuff like that. And certainly that's a subject of a whole nother us two meeting. But on the other hand there is a lot of excitement and a lot of movement and developments that are ongoing in this space, because again, if we can find it, localize it early, we have the potential to help a lot of patients, we believe, at earlier, more treatable times. So kind of stay tuned because I have a feeling even in the next year, if I gave the same kind of question and answer talk, we will come up with a whole bunch of new stuff to report out.
Excellent. Thank you so much, Brian. And we will definitely have you back.
Thank you guys so much.
So again, thanks so much, Dr. Helfand. So I'm so excited to introduce our next guest, Dr. Laurence Klotz. And Dr. Klotz will present on novel tools in the active surveillance pathway with a discussion on imaging, and we're going to get a little bonus. We're going to get some more on biomarkers and interventions to improve health and reduce likelihood of progression. Dr. Klotz, take it away.
Thank you, Terry, and hello, ladies and gentlemen. And let's just see here. Share screen. Okay. Really, it's a great pleasure to be here, and I'm impressed that as a group, you're taking a couple of hours on a summer's night. And of course, for the hockey fans, this is also conflicting with what could be the last game of the semifinals between Montreal and Las Vegas. So I won't assume that any of you are feeling the same sacrifice that I am, but it'll be interesting to see what happens. This is Toronto looking at its best. It does look like this about 2 weeks a year when we have decent weather, but it really is a beautiful city, and I encourage you to visit once the border loosens up. These are my disclosures, and I will be mentioning the products of these two companies, Mir Scientific and Exact Imaging. So I'm going to make the focus of tonight's talk active surveillance, and I heard there were some questions about this that I think I will address in the course of this talk. But this idea has gone from being something that was really controversial, seen as a threat by many of my colleagues. It certainly undermined the business model of urologic surgeons and radiation oncologists who were treating a lot of patients with grade group 1 prostate cancer. But two, I think the credit of the profession, the world did change. The evidence was incontrovertible that these patients did not require radical therapy. And it really is remarkable how all over the world now, active surveillance is seen as the standard of care for grade group 1 prostate cancer. So the controversy now is over not whether the principle is valid, but exactly what the application is. Who's a candidate? Can we offer it to intermediate risk patients? The question about biopsy that was just asked, can we replace that with imaging? How often, and so on. Now, I just thought, I know this is not a medical group, and I confess I usually do speak to my colleagues more than I speak to patient groups. So I just thought, these are some acronyms that are going to come up. Prostate cancer grade group is the grading system. GG. These are oncology acronyms that are widely used. OS for overall survival, CSS, cancer-specific survival, PFS, progression-free survival. AS is for active surveillance. US is ultrasound. And I'm going to show a few of these forest plots. So if you're not used to looking at these, this is how a huge amount of information can be displayed very succinctly. So this is an example. It's not from the field, but each one of these are individual studies, randomized studies. And this is the benefit or not. So the gray line here is called unity or 1.0. And if that square is right on top of unity, it means there was no difference seen. If it's on one side, it means that side was better. If it's on the other side, that side was worse. The bigger the square, the more patients. The line is the confidence limits, meaning how much variation can you expect. And the key thing is this diamond at the bottom, which is called the effect size, or kind of the overall, the amount of benefit and how confident you can be that that benefit is real. So that's just sort of a quick primer. And I apologize if you're seeing acronyms that you're not familiar with. So just begin with kind of an overview of this topic of grade group 1 versus higher grade cancer. And there's been a huge effort over the last decade or so to really understand the molecular genetics of low grade versus higher grade prostate cancer. And what has become apparent is that the molecular genetics of Gleason pattern 3 or grade group 1 in about 90% of cases is normal. So for example, many aggressive prostate cancers have a tumor suppressor gene that is lost or deleted. It's present in grade group 1 in most cases. Or they have an oncogene, a driving gene that is upregulated or increased. It's normal. In higher grade cancer, these are invariably altered. So there's a real profound difference in the molecular genetics between low grade and higher grade prostate cancer. And the implication of this is that the metastatic potential of Gleason 3 or grade group 1 is 0. This entity never, ever metastasized. And I've made a hobby out of this. I have probably spoken to thousands and thousands of clinicians over the last couple of decades. And I often ask them, how many of you have a patient who had only grade group 1, had a radical prostatectomy, which we don't believe is the right thing to do anymore, but it was different a few years ago. And despite the surgery, the patient ended up with a recurrence and a metastasis. And the reason that the surgery is important is because on biopsy, the patient can be grade group 1, but they can harbor higher grade cancer that can metastasize. So there's a distinction here between the biopsy finding and the finding when you can subject the whole gland to pathologic examination. And in the whole world, and this probably represents millions of patients, I know of a handful of cases, fewer than 5. So I think this is a safe statement that grade group 1 never, ever metastasizes. And that has a lot of implications for management. A question which probably has come up with this group is, should it still be called cancer? And that's a debate at the moment. It can invade locally, and there's a number of other cancers in the body where it's not a controversy. For example, basal cell cancer of the skin, and also some brain tumors like gliomas, which never metastasize either, but can invade. And there's really no debate with those about calling them cancer. So I don't know if this is going to change. There is an initiative to change the language to no longer call grade group 1 cancer. I don't know what's going to happen to that. So I mentioned the issue of grade group 1 metastasizing is not that what we know the patient has any metastatic risk. It's that in a significant proportion of these patients, you find grade group 1, but there's something more there, higher grade cancer. The term I use for this is misattribution of grade. When we did systematic biopsies, only it was about a quarter to a third of patients. It was really common. Now, increasingly with targeted biopsies, It still happens, but it's probably in the range of 10 to 15%. So much less of an issue. That's one of the huge advances of MRI. The other side of this coin is, let's say the patient has had his targeted systematic biopsies. There's no evidence of higher grade cancer. How likely is it that this will progress to higher grade cancer over time? And this is something that patients are always worried about. And we have now a handle on that. There's a total of 3 studies. One of them was one that I did, but this is I think the best one from Seattle. And all the 3 groups that have published on this have come up with the same number, 1 to 2% per year. So it happens, but it's not common. It usually occurs where you have quite extensive low-grade cancer, like a field of Gleason 6 cancer or grade group 1 cancer. And usually that upgrading is to Gleason 3+4, which also is often indolent. So it doesn't mean the patient's going to die. It means that they're at higher risk for having clinically significant cancer. I call this the wolf in sheep's clothing, where you do the biopsy seeing grade group 1, but actually there's a more lethal cancer underneath. So this is the Achilles heel. This is our data just showing over time the rate of true grade progression based on serial biopsy. And again, we get the same figure, about 1% per year. So how can we do better with active surveillance? This is where I'm going to get into the imaging and the biomarker story. We can find fewer cases. Most people believe, including myself, that a man is not necessarily better off knowing that he has grade group 1 prostate cancer. It first of all scares the hell out of him, at least until he understands that this is not a significant disease. And it results in a lot of additional tests. And, this has an impact on quality of life. So we're going to do this perhaps with better case selection for biopsy and with image-guided biopsies. We know we've actually just published a randomized trial comparing systematic biopsies to only targeted biopsies in men who have a target. And the number of grade group 1 cases dropped by more than 50%. So with targeted biopsies, we're going to see less of this. Imaging to detect occult disease earlier. So the thing that no one wants, everyone's worried about, is the guy whose biopsy shows Gleason 6, but there's an aggressive cancer, usually anteriorly in the prostate, which is a harder area to biopsy, that is potentially lethal. So imaging has come a long way with this. I'll come back to that. Better biomarkers, artificial intelligence is going to have a role in this, and innocuous interventions, which I'm going to mention briefly at the end of the talk. So I'm going to cover most of these. And just to give you an idea of what's happening in this field, a lot, and I can't cover it all tonight, but the impact of germline mutation analysis. So germline means your genetic inheritance that's in every single one of your cells. And we're now learning that there's some specific mutations that predispose to prostate cancer, particularly aggressive prostate cancer. So identifying those, integrating liquid biomarkers in urine or serum with imaging. This is called radiogenomics. New imaging modalities, which I'll come back to, molecular imaging, genetic cancer profiling using imaging and understanding what specific, very detailed patterns of the appearance on MRI, for example, means, the impact of diet, exercise, other lifestyle changes to reduce the risk, and innocuous drugs. So first, a little bit about where I think the biomarkers have a role. And I know you had a lecture on this not too long ago, so I'm not going to go into much detail, but this is really important. The first is what we've learned about what's called BRCA mutation or DNA repair defects. And these are inherited mutations in a gene that is responsible for the mechanism by which cells repair mistakes in genetic replication. So of course, cells are dividing all the time. Each time they divide, they have to copy their DNA. There's 1 billion base pairs. It's not surprising that periodically there's a mistake made. And to avoid genetic chaos, the body has a number of mechanisms. Each cell has a number of mechanisms to identify when there's been a mistake and to either correct it or to have the cell undergo cell death. So this is really kind of essential to having genetic stability. And what happens, so some people are born with a defect in this repair pathway called DNA repair pathway. And the most important one is called BRCA. BRCA1 and 2 was initially described in breast cancer. This stands for breast cancer gene, but it's also very relevant to prostate cancer. So this shows what happens in the normal situation, so-called sporadic tumors. Initially, you get loss of some key tumor suppressor genes, and then acquisition of some oncogenes. And over time, you get sequential aberrations accumulating in the genome, but it takes a long time, 10, 15, 20 years. There's evidence that, for example, about 30% of men in their 30s harbor small bits of prostate cancer, and this may not show up for 30 years in terms of a clinical disease. It's a long-term thing, and this lends support to the idea of surveillance, where you can expect stability in most patients. In contrast with BRCA mutations, boom, you get one abnormality, and then there's this explosive acquisition of genetic aberrations in a very short time frame. So if you're talking about managing a patient on surveillance, that is not a good basis for going forward. It's estimated that about 3% of the overall population have these mutations, about 10% of men with prostate cancer, but it's particularly common in men who have bad prostate cancer, who have metastatic disease. The BRCA mutations are present at about 8 times the likelihood in those men because it confers such an aggressive characteristic to the cancer. Now, how do you recognize? And just one other point, there's 1 or 2 studies now in the literature, it's just beginning, that show how men do on active surveillance who have the mutation. So this is from Hopkins, large group of men who are normal and 26 who have some kind of DNA repair defect, again, germline, meaning they've got it in every cell in their body. This is HR's hazard ratio. The likelihood of progression to higher grade cancer with the BRCA2 is about 2.7 times greater. And you can see here by 10 years, almost close to 100%. The figure's around 80, but I think it should be 100 if they really characterize the patients completely, have progressed to higher grade from lower grade cancer. So the message is active surveillance is great, but not for men who have a defect in DNA repair pathway. And how do you recognize them? This has now become extremely inexpensive and widely available. It used to cost $50,000 to get this done. It's now $249 US. You go to color.com, you pay the $250. The patient gets sent a kit with some test tubes, sends back some saliva, and a couple of weeks later gets his hereditary, the characterization of his genetic inheritance for cancer susceptibility genes. Not everyone wants to know this, but I think in men with prostate cancer, it's important. And I increasingly am encourage patients to do this, particularly when there's any history of familial prostate cancer or breast cancer or ovarian cancer. Those are the most common cancers that go along with this. And then there's a whole slew now. There's about 10 different commercially available biomarkers that all are trying to identify the patient's risk of having higher grade cancer. Some of these are in blood, some in urine, some in tissue. I'm not going to go into detail. They all work. they all have a performance or an accuracy that's around 80%. The one with the highest accuracy, this stands for area under the curve, which is sort of both sensitivity and specificity together, is around 90% with the select assay. But this is a very rapidly evolving field right now. They're not cheap. The liquid ones, blood and urine, are mostly around $500 to $700. The tissue-based ones, where the cancer cells are dissected out from the biopsy and subjected to what's called whole exome sequencing or genetic characterization, are quite labor intensive and in the $4,000 range. I'm just going to, there's a new one coming out, which I'm quite involved with. I'm just going to mention briefly, called the Sentinel assay. And this is a urine-based assay that's based on something called urinary exosome microRNAs. So these exosomes are are tiny packets of material that are excreted by cancer cells. So a typical cancer cell may excrete several thousand of these exosomes per day, and they contain important biological material, and particularly these microRNAs, which don't code for proteins, but they're regulatory. And they can be used, they characterize cellular abnormalities. So basically, the assay takes about 445 of these microRNAs and sequences them, and each one has predictive value. So when you put them together, this is sensitivity and specificity. This is amazing performance. Like here, I showed the area under the curve for the best assay that's out there. The select one is 0.9, and here you have 0.96 to 0.97. So this is coming down the pipe, and I think it's potentially a real game changer. If you can do a urine test and say with 97% accuracy that the patient has or does not have clinically significant prostate cancer, that's going to be a whole new world of prostate cancer. I'm very excited about that. Now, imaging. So this is what an MRI of the prostate looks like. And the first thing I just want to point out is the amazing level of detail that you see in these images nowadays. So this is a 3 Tesla. The Tesla is the kind of power or the resolution of MRI. And, you know, this is unprecedented. We never saw images like this before. And this is a patient who initially was on surveillance, and he had a biopsy that showed Gleason 3+3. And in the olden days, he would have had a confirmatory biopsy a year later, and maybe we would have found something, but probably not. Today, he gets an MRI, and there is the lesion right there. Now, the biopsy traditionally was done transrectally this way. So you can imagine the likelihood of hitting something like that coming in from the rectum. You'd have to, you know, even a blind pig finds a truffle, so you might hit it once in a while, but usually not. But today, MRI, targeted biopsy, and the targeted biopsy showed Gleason 4+3, prostate cancer, really very significant disease. And this is called a whole mount of the prostate. So this is a cross-section of this man's prostate. The Gleason 3+3, which is completely insignificant, is there. And he has a large, high-grade anterior cancer. These are the kind of cases that resulted in the metastasis and death from prostate cancer in about the 1% to 3% of men followed with surveillance before MRI. And now we're finding them earlier. So it's really it's a game changer. But it's not perfect. First of all, it's not real time. That means the patient has to come, have his MRI, it has to be read, then he has to come back for what's the fusion targeted, where the MRI image is superimposed on the ultrasound. There's a lot of potential for error with this process. So, and it's 2 visits. The radiologist really needs to know what he's doing. There's a considerable learning curve. If the patient's had some treatment, it creates some artifact. It misses lesions. I'll come back to that. It's expensive. It's complex. A lot of men are they have one MRI and they say, there's no way I'm going back in that thing. they have claustrophobia. I can't get over how common that is, but it's a real phenomenon. If patients have had hip implants or pacemakers and so on, they may not be able to have one. Access is an issue and coverage is an issue. I'm in Canada. We are definitely under-resourced in terms of MRI. It's a constant battle to get them. So it has real limitations. And aside from those issues, I just want to emphasize that it misses a significant proportion of cancers. And, you know, when this first came out, me and my colleague, we were so excited by this. Like, it was called the GPS of the prostate. You can now see the cancers, find them. You don't have to go blindly biopsying them. Images are very powerful for surgeons. You can see where the lesion is. You can kind of make decisions about how extensive to resect and so on based on an image, not just a biopsy. But although it's dramatically improved the situation, it's got limitations. So here, this is a study from UCLA. Just look at the bottom right here. So this is the correlation between the MRI findings and what was found at the time of surgery when the whole prostate was taken out, comparing the MRI findings to the actual pathology. And these on the bottom right were the patients who had multifocal cancers, which is true of most patients with prostate cancer. They don't have it in one spot, they have it in a few spots. You can see here almost about 75% of these cancers that were less than 1 centimeter were missed. The majority were missed. And overall, 40% of grade group 2 cancers, a quarter of grade group 3 cancers, and so on were missed on MRI. So it's good, but it's not perfect. It also underestimates size. And I'm not talking tonight about focal therapy, partial gland ablation, another really fantastically interesting topic that I'm sure many members of your in the audience are curious about. But with focal therapy, you identify the lesion on MRI and then you treat it. But we know that the MRI tends to underestimate the cancer volume by about 1/3. So here you see the MRI on the bottom left, and then here is that prostate, and you can see the volume of the cancer, which is the blue stuff, is considerably larger. And this is a graph showing the correlation between the pathologic and the tumor size, and it's kind of all over the map. That's not that closely correlated. And you can see here in the study, the mean MRI volume was 1.6 centimeters, mean pathology size 50% greater. I'm not going to talk about PSMA in any detail. You just heard about that. Just one slide about whether PSMA is going to be better for imaging localized prostate cancer. And this is a work in evolution, but at the moment, the data is that PSMA really doesn't add much to MRI in terms of identifying the local extent of prostate cancer. PSMA is great for identifying sites of recurrence. In Canada now, we've had it available for about a year and a half or 2 years, but we really only exclusively use it in patients who've had radical treatment and then they have PSA failure, or they're on hormone therapy and they're developing rising PSA, hormone resistance. That's when the PSA really has value. But in this situation of identifying extent of localized disease doesn't seem to have much. So you can see here the incremental cases where PSMA only shows the disease is the yellow here, and it varies between about 2 and 5 to 10%. But for the cost and the inconvenience and so on, it's fairly limited. Whereas really MRI shows the vast majority of these. So this leads me to the main innovation that I want to talk about is this high resolution microultrasound. This came out of University of Toronto, my school. And this looks like a regular ultrasound, but this is like having a Lamborghini in the garage. And the reason I say that is Conventional ultrasound has a resolution of 200 microns or 0.2 millimeters. And that is enough to outline the prostate very clearly, but it's not enough to see alterations in the structure of the tissue inside the prostate. This device, because it's a higher frequency, 29 megahertz compared to around 6 or 7 megahertz with conventional ultrasound, the resolution is about 3 times greater, 70 microns. 70 microns is the diameter of a prostatic duct. And the principle of MRI visualizing cancer is that you get changes in the ductal anatomy, the pattern of glands and ducts in the prostate. With higher grade cancer, the glands tend to be more packed together and you lose the spaces inside them. So with MRI, it means the diffusion of water is restricted. With ultrasound, you see this. If you have high resolution, you see the changes in ductal anatomy. And that is really what gives this its power. In contrast to MRI, it's pretty inexpensive. It's about the same price as a regular high-end ultrasound. And it doesn't require a full-time technician. MRI is super cooled magnet. I mean, it's really it's a very complex piece of technology compared to this. And just to show some examples, so this is sort of what a conventional ultrasound looks like. This is the prostate. And here is the magnified view. And you can see this kind of speckled pattern here, which we call Swiss cheese. So this is what a normal peripheral zone of the prostate looks like. And you get loss of this speckled pattern in a number of different ways, is what cancer looks like. And you get these patterns of cancer. This is called bright echoes. And this is, in this case, a Gleason 8 prostate cancer. You can see anatomy very clearly. So this is the neurovascular bundle. You just don't see this with conventional ultrasound with nearly the same clarity. And remarkably, this is a guy who had needle biopsy 5 years earlier. You still see the needle tracks. Again, you don't see this with conventional ultrasound. In fact, I'm not sure you see this too well well, you do see it sometimes with MRI. I'm going to skip this slide. Not sure how that got in there. So with MRI, you have this grading system called the PIRAD system, goes from 1 to 5. 4 and 5 are suspicious for cancer, and this analogous system called the Primus grading system, prostate risk identification using microultrasound, has been developed. And the Primus 1 and 2 is this kind of uniform appearance, Swiss cheese, or maybe Havarti is a better analogy. As you get into cancer, you start seeing these abnormalities like bright echoes. You see smudging, cauliflower appearance, mixed echo. It's actually quite easy if you're used to ultrasound to learn to recognize these. And this I think graphically shows, I hope this works, what happened. So if this was a patient who'd had an MRI, you probably would have seen this lesion here, and the radiologist would have read the MRI, hopefully identified it, marked it out. Then the patient comes back another time, has the fusion targeting. Hopefully it works. And because you can't see this kind of thing with regular ultrasound, and you hope the needle goes into the site. Whereas here, the patient just comes for his ultrasound and you see the lesion and you line it up and boom, I hope. Yeah, and there the needle goes through. You can be essentially 100% confident that you have targeted this lesion accurately. So this really is appealing compared to the kind of two-step approach, and also less room for error. And this is some preliminary experience with this. So this actually represents the results of about 1,000 patients from the first 11 sites around the world. It's from about 5 different countries that started using this microultrasound. And although this partially reflects the learning curve, and it's not perfect, but you can see this is the forest plot I was referring to. The sensitivity of the ultrasound is as good or better than MRI. It actually looks a little better here, and the specificity, which is the false positive result, is about the same. So this was really encouraging because here you have kind of a inexpensive, relatively simple technology that works about the same as MRI. And I think it's new, but this is, I think, gonna take off and be an alternative to MRI going forward. You put all this together, the biomarkers, which hold huge promise, imaging, which is getting better all the time. And I think we're moving to an era of what's called dynamic risk profiling, where instead of having, and I know there was a question previously, can imaging replace biopsy in men on surveillance? The short answer is, to a large degree, yes. Maybe not completely. We still need biopsies to make a tissue diagnosis. But I think with imaging and biomarkers, we're moving to a stage where over time, you monitor these things. For example, you have a urine test that's 98% accurate, and it's negative, 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 and suddenly, a couple of years down the road, it switches to positive signal for having significant cancer. That is going to change how we look after this, and that will be very reassuring to patients. It will avoid the need for biopsy in all but those patients who you can be almost completely certain have more aggressive disease. And ultimately, we may reach a point where patients are treated without the biopsy based on extremely reliable liquid biomarkers. And then another challenge is how to integrate all this information. So you can see the challenge. You don't just have the Gleason grade and the stage and the PSA. You increasingly have data from imaging, maybe PSMA, the results of the urine, the blood test, the biopsy, the germline testing gives you information. Maybe there's isoforms of PSA. You've got data about the patient's family history, race, diet, all of this stuff. The human brain is not good at integrating this, but artificial intelligence and big data is designed for this. So there's now a major initiative based in Australia to develop an AI application that ultimately will contain data from, say, 50,000 patients on active surveillance, and you can input your patient's data and get an extremely accurate prediction of how that patient is going to do, which can then drive management. Now, the final part of this talk is interventions. And, when you see a patient newly diagnosed with prostate cancer, they often have other health problems, and those other health problems may pose a greater threat. But suddenly, with the cancer diagnosis, you have their attention. And so it's really an opportunity to intervene in a way that will help their general health as well as their prostate cancer. So I divide this into kind of two sets of recommendations. These are the motherhood recommendations. Everybody knows this, but they don't necessarily do it. But when they're diagnosed with prostate cancer, even if it's clinically insignificant, they are listening. Smoking cessation, the single most cost-effective intervention in all of medicine. And I really think that my colleagues should embrace smoking cessation activities more than they do. 2 minutes spent by a specialist under the right circumstances has been shown to actually have an effect on smoking behavior. Regular exercise. If exercise were a pill, we would all take it. This is a picture of the 8 or 9 different ways that exercise has been demonstrated to favorably influence the tumor microenvironment in prostate cancer. It influences hormone levels, growth factors, cytokines, which are regulatory molecules. It influences the what's called epigenetic modulation, the alteration, not so much of the genetic DNA, but the expression of specific genes and so on. So exercise, you can't emphasize this enough. And dietary modification, heart healthy is prostate healthy, weight management, avoid obesity, moderate red meat intake, increase fruits and vegetables. So this is just kind of general good health advice, but it's particularly applicable in these patients. A question that often comes up is, should patients modify their diet once they're diagnosed with prostate cancer and they're managed on surveillance? It makes sense, that maybe if you go to, for example, switch to a vegetarian diet, less risk of progression of prostate cancer, because we know diet does influence the likelihood of prostate cancer over a lifetime. So we've just had some really good data on this from a large-scale randomized trial called the MEAL trial, where in about 500 patients, half got aggressive dietary counseling, professional counselors, phone calls, etc., to switch to a vegetable-based diet versus a pamphlet, which the assumption was the pamphlet wouldn't have much impact, and I think that was correct. And what did they find? After 2 years, unfortunately, nothing. No difference in any prostate cancer parameter after 2 years of patients switching to, they did switch their diet. The intervention was successful in getting the guys on the intervention arm to largely give up meat and switch to vegetables, but might have been good for their health, but it had absolutely no impact on PSA, on repeat biopsy findings, or anything else. So I think the message is that your diet over a lifetime clearly influences your health. But once you're diagnosed with prostate cancer, it's probably too late, at least in the short to intermediate term, for dietary modification to make a difference. I tell people what I showed on the last slide, heart healthy, but you don't have to make any drastic changes. This is really recent, fascinating data, just published in the New England Journal, about how obesity affects the tumor microenvironment. And it turns out that in obese men, the tumor cells increase their fat intake. And what happens is the immune cells in the body, which are there to kind of keep the tumor cells under control, get paradoxically starved of fat. So this is just a very recent observation. And what that means is the immunity, the anti-cancer immunity, is impaired. And this is probably the mechanism by which obesity, we've known for years that men who are obese have an increased rate of prostate cancer, increased rate of advanced disease, increased rate of metastatic disease. This is probably the reason. Oops. Sorry. And then finally, interventions that these are not proven by prospective randomized trials, but these are really supported by preclinical and epidemiologic studies. They're innocuous, they improve patients' health, and I personally think they're warranted. Vitamin D, low-dose statin, and metformin. So vitamin D, this is particularly for people living in northern climates like Canada, northern US. Vitamin D deficiency is ubiquitous in the elderly. It's the norm. And there's all kinds of data. This is another forest plot of 7 or 8 different studies showing the relationship between the likelihood of dying of prostate cancer according to your vitamin D level. Clearly a consistent relationship between all these studies. So vitamin D costs about 3 cents a pill. I encourage all my patients to be on vitamin D supplementation, usually around 1,500 units a day, which means one pill plus a multivite. Statins. So this is a long story, but statins have obvious health benefits in terms of improving the lipid profile, cardiovascular disease, but also they play a role in prostate cancer. And there's a pathway called the mevalonate pathway that leads to molecules that stimulate the growth of prostate cancer, like insulin-like growth factor 1 and so on. And here's the epidemiologic data showing that men on statins have a lower rate of prostate cancer metastasis, overall survival or mortality, and prostate cancer specific mortality. So again, remarkably consistent between the different studies. And so I think I'm very pro-statin. I think most men in the age group, meaning over about age 50, particularly who are diagnosed with prostate cancer, should be on at least a low dose statin. And then finally, metformin. Metformin is an old drug used for diabetes. And metformin looks very much like a kind of a health promotion drug. It's very safe. Non-diabetics who go on metformin do not develop low blood sugar. They really have no symptoms or evidence of this at all. And through two pathways, a direct and an indirect pathway, metformin looks like it can inhibit cell growth in prostate cancer. And it also has other metabolic effects. It prevents diabetes. And insofar as we've got an epidemic of diabetes, I think it makes a lot of sense, particularly for overweight men, to go on metformin as a preventive strategy, but specifically in the prostate cancer area. And again, another forest plot showing the effect of metformin in prostate cancer. And you look here at the bottom diamond there, and all of these studies, it's a very consistent result that men on metformin, so these are generally studies of diabetics, whether they're on metformin or not. If they're on metformin, they have a lower rate of progression and improved prostate cancer survival. We are doing a randomized study now in Canada of metformin in men on surveillance to try and prove this. We should have an answer within another 3 or 4 years. So to conclude, active surveillance, it reduces morbidity cost, and you need to employ active surveillance and not overtreat all those patients for low-risk prostate cancer. It does require ongoing active monitoring. The imaging developments that I've talked about, the biomarker developments that I've talked about, are really going to transform this field and make it even more appealing for patients. Thanks for your attention. I hope we have time for questions.
Hey, Dr. Klotz. Can you hear me?
Yes, I can.
Excellent. So we're almost out of time, but I've got a couple questions that might be, I'm just going to try to squeeze them in because.
Fire away.
So first question is MED12 actionable?
I can't answer that because I don't know what it refers to.
Okay.
MED12. I'm sorry.
Yes, that's okay. And I didn't either, but I thought maybe you might. So here, let's see, here's another one. Do any of the genetic tests have value for someone who has had ultrasound treatment?
Well, so that's a hard question to answer because there's genetic tests covers just such a huge range. So there's the germline testing that I talked about, the color.com. That's to tell about susceptibility and also whether your family members are also susceptible. The liquid biopsy tests are useful in someone who, say, has low-grade cancer, and the question is, have they got something more? And the tissue-based ones really are, it's the same idea, to dissect out the cells and see if they have adverse genetics. So if someone, so I'm not sure what it means, someone who's had ultrasound, maybe that means HIFU. I can't really answer that because if they've been treated curatively, they're cured. They have no, and they're followed. These tests may have a role going forward in men who have been treated, for example, with focal gland ablation, and do they have any evidence of recurrence in the untreated area, for example. So the short answer is yes, they'll have a role, but we're probably not quite there yet.
Okay, we're gonna we have one more time. One more question. And this is a good one because everyone can relate to this. Can metformin be taken temporarily?
It can be taken, absolutely. I mean, it's extremely innocuous, like safe drug. A patient can take it, go off it. It really has essentially no clinical effects. A few patients get diarrhea on it, which usually stops after the initial few days. I just want to emphasize, we don't have randomized trial data supporting this. So this opinion that I'm giving is really my own. It's inferential based on a lot of data, but not prospective randomized comparative placebo-controlled trials, which is what you're supposed to have to make a recommendation. But I kind of fudged that a little bit because I think here you've got a cheap, harmless pill that seems to have a lot of advantages.
Thank you so much, Dr. Klotz. Well, it's been a total honor to have you with us tonight.
All right.
Good luck to your team.
Pleasure.
I just want to thank everyone again for joining us tonight. And I especially want to make sure to thank our sponsors one more time, Pfizer Astellas, Blue Earth Diagnostics, and Progenics. I want to also mention this webinar has been recorded and you will all get a copy of it. It could take about a week. It could take a little bit longer, but you will all get a copy of this recording. So, and I just want also to mention, we have another webinar coming up. It'll be our last in the series of 5 on July 29th on genetics and genomics. So keep an eye on your email for more details on that. So once more, thank you so much again to Dr. Helfand, Dr. Klotz, the S2 team for all the work that goes on behind the scenes to put these webinars together. So thank you, everybody.
Thanks, Terry.
Y'all have a great night. Stay safe.
All right.
And stay
Bye-bye.
healthy. Thanks, everyone.